Preventive therapy, you said if a patient has frequent attacks, then you put them on a long-term prophylactic therapy for migraine. What are the choices available and what is your choice?
I think here one has to individualize depending on the factors, So for example, a person has a lot of, after there are migraine triggers. So if the migraine is triggered by sleep disturbance or stresses, then my first choice will be amitriptyline. And you start with 10 milligram and maximum you can go up to 25 and most of them will respond. If it is a male patient who does not have stressors as the main criteria, then I would go to flunarizine as the drug choice. And finding flunarizine, even 5 milligram is sufficient. You do not go to 10 milligram in every patient. Most of them will respond to 5 milligram, only few of them require 10 milligram dose. And of course, beta blocker also, propranolol is also, or metoprolol is also a good choice in this. So you also have to consider the comorbid conditions. So if a comorbid lady who is overweight, say about 50 kg or 180 kg or something like that, and she has migraine, which I require prophylactic, then probably I would resort to topiramate as a good drug because topiramate will reduce her weight gain. There's only antimigraine prophylactic drug which is associated with loss of weight. Most of the other drugs will maintain weight or lead to weight gain. Only topiramate is the only drug that helps us in reduce weight. Mind you, when you will use topiramate, make sure that person does not have a history of nephrolithiasis or renal stone. And they should not have high myopia because my number can suddenly change and can cause glaucoma. And my example, the important for and the other thing is start slow and go slow and try to remain as low as possible. My experience with topiramate is bad in the sense that I described this to one of my high school teacher and I must have just given 25 milligram a day. And in the next time, she rang her 3 to 4 times that she's going to her class and she's not able to teach. She can't find her words properly. So she never came back to me, stopped topiramate, never come back to me. So make sure.
What you're saying is not a vision problem,
but a memory problem.
One side effect is
one of the important side effects of topiramate. It can come very early and even with a small dose. So educate them and if they get it, get the drug out and they will use the teaser. And of course the other drugs, if weight gain is not an important consideration, then sodium valproate in the divalproate is a really good drug, and particularly if you have depression associated with it, it's a good drug because it has a good mood stabilizing effect. So bad and increasingly being used, but of course weight gain is a major problem as Tommy pointed out.
Okay, to the next subject which we go. Epilepsy is a disease which we don't commonly treat as a family physician. We usually refer epileptics to pediatric neurologists or adult neurologists. And our duty, of course, will be when a patient presents with the first episode of seizure. The first episode of seizure does not make a patient epileptic. So how does a family physician deal with the first episode?
I think it's a very good question because first of seizure, one has to first, that's why I think in brief I must introduce the subject by saying that epilepsy is a disease, by definition, is a chronic disease of tendency to having recurrent seizure. So every person who gets seizure does not mean he has epilepsy. That's the first point we want to make. So if a person gets seizure, you need to go into details to find out what is the etiology of that particular seizure. So seizure is just a symptom of something going on, either metabolically wrong or it is maybe a drug withdrawal effect that the person is alcoholic and he withdraws from alcohol and gets a seizure, or maybe he has neuroglycopenia and that's why he gets seizures, so he has been given some drug for malaria and he gets seizures and so on and so forth. So what is important is to take good history, decide whether it is a seizure or is a seizure mimicry. That means you have to be sure that the commonest cause of episodic loss of consciousness is not epilepsy or seizure, it's syncope. So make sure that it is not syncope, it's cardiac syncope or a vascular syncope, it's a seizure. So diagnosis is appropriate, is the first thing. And then once you are sure that it is a seizure and he's already finished seizure and come to you, there is no rush to start antiepileptic therapy. What one could at the most give, if you are worried, is a clobazam, that is the free stem of clobazam is available, which is a good antiepileptic property without many side effects. So while you are waiting investigations and deciding to refer and all that, maybe you will give 5 milligram or 10 milligram tablet of clobazam and then working up. Workup should include biochemistry, have to do sugar, and then followed by an imaging and an EEG. EEG must be done as previously used to see that EEG should be done say maybe 6 weeks later. But that's not true. I think if you do EEG within the first 24 to 48 hours, the yield is maximum. Because as you know, EEG is almost normal in 50% of patients with epilepsy or seizures. So if you want to pick up a community on EEG, try to do it as early as possible. That will help us not in the diagnosis, it's going to help us in the classification of seizures in future because you have to decide what therapy we will do. And of course, imaging is required. If anybody who develops seizures after the age of 20 or in adult, I think you need to find out in etiology and either CT scan trained with contrast or in a children probably I would prefer MRI if the cost is not a factor because it gives you many more information than what CT scan gives.